We now invite Dr. Sean, who is an alumnus of Goa Medical College and Arvind Eye Hospital, Madurai. He is presently the cornea consultant and medical director at ASG Eye Hospital, Goa. So looking forward to hear from Dr. Sean.
Thank you very much, Dr. Girish, and thank you for my colleagues in the audience. I just thought I'll cover up a few practical approach to management of keratoconus. Many times we do not have access to all the possible gadgets and devices available, but a few things of how the whole management of keratoconus has changed over the last 15 years. I think it was during the PG that we actually considered keratoconus as an ectatic disorder characterized by thinning and protrusion. It was invariably bilateral with asymmetric involvement, more likely to be progressive in a younger patient and less progressive in an older, and traditionally was considered non-inflammatory in the textbook definition, but however the concepts have now changed to consider it as a possible inflammatory etiology. We'll just go into the overview of the epidemiology and risk factors first. Again, prevalence varies widely in the general population. Asians have a greater prevalence. Family history can be variable. In Goa, we do not have too many patients having a family history of keratoconus, but in certain populations where marriages happen within the same community, they tend to be more common. Ocular rubbing, no doubt, has been the most important cause in cases with keratoconus. You have to look for associated signs of atopy, any ocular allergies, patients with Down syndrome, and these patients tend to rub their eyes. We've had patients with just having unilateral keratoconus where the only risk factor was eye rubbing. At the Indian subcontinent, we find cases at a younger age which progress more rapidly. Again, genetically, majority of the cases are sporadic, with family history in maybe 10% of cases in the reported literature being autosomal dominant. Autosomal recessive being more common, and first-degree family members at a higher risk. This is especially important when you're considering refractive surgery in a patient, whether there's any patient who was denied refractive surgery due to abnormal corneal topography. The SELECT study also reported a positive family history of 14%. So take a detailed history, look for the systemic findings in the patient, look for underlying connective tissue disorders, eye rubbing, abnormal retinal functions, and evaluation for atopy, hay fever, and asthma. These patients may require an reference to an allergy specialist for a complete allergen testing and even immunization if required. In the pathogenesis, we understand the degradation of corneal collagen and altered enzyme activities, increased MMP levels, and decrease in the tissue inhibitors of MMP. Increase in tears, a lot of tear studies which were published and even presented in the previous talk. And this reinforces that there is some inflammatory mechanism happening over there. Currently, we do not have any drugs targeting these interleukins and the other factors, but eye rubbing associated with interleukin-1, and in most patients I do tell them, please write no eye rubbing and stick it on the mirror every day so you remember not to rub their eyes, especially in children. The early diagnostic signs, here I'm presenting a 15-year-old girl who presented with just a slight change in her cylindrical power, 2015. Compared to her earlier 2014 records, we saw a bump in the cylindrical power on refraction. She was not improving to 6/6, and history of recurrent adenoids since childhood. We went ahead and did a topography, and we did find in the sagittal maps having an increased steepening in the superior areas, as well as an early bump on the Berlin-Ambrosio display. So a high index of suspicion is most important, especially it's very unusual for a person having a cylindrical power to be jumping at every visit. A non-orthogonal astigmatism on topography, vision not improving to 6/6, a significant change in the cylinder over the last 6 months, and history of associated ocular allergy can be always emphasized. The early diagnostic signs can be picked up with a very good refraction as a scissoring reflex on retinoscopy. Look for a retroillumination, the oil drop sign, and of course the Vogt's triad and the Fleischer's ring. Having even a basic anterior maps with the Placido disc device like the CVK can also pick up the abnormality in the anterior curvature. You have various indices related to that. The OBSCAN was the first device combining the Placido disc with the slit lamp image, and this provided good maps of the posterior float of the cornea as well as a global pachymetry. However, the Pentacam changed the entire aspect of evaluation of keratoconus, the anterior segment tomographic device, which had a slit image rotating in the central cornea, providing a better representation of the central cornea, with evaluation of more than 25,000 true elevation points. The entire principle was based on Schumflug's principle, which describes the optical properties involved in photography of objects when the plane is not parallel to the film of the camera. Theodor Schumflug was a Swiss Army person, and he identified that in these images, if you want to take a proper image, especially if you're analyzing a corneal image on a slit beam, you need a camera which can actually evaluate even objects beyond focus, and this was a Schumflug principle, where the image plane, lens plane, and subject plane are not parallel to each other, and they intersect at the Schumflug intersection line. This is what's being used in most of the movie cameras for film shooting. The advantages of a OBSCAN were numerous, with limbus-to-limbus measurement, better representation of the center, and more accurate representation of the posterior surface. The red flags were the asymmetry, 47.2 and above keratometry, inferior temporal thinning, and changes on the anterior and posterior float, which would pick up early keratoconus. This was further analyzed by Michael Berlin and Dr. Renato Ambrosio, who devised the Berlin-Ambrosio maps. And here the goal was to combine the elevation-based data and the pachymetry in an inclusive display, which was more sensitive in detecting the ectatic conditions. Here in the anterior maps, identifying a focal bump by subtracting the central thinning area and looking for any abrupt thinning in the progression maps. What they did was excluding 3.5 millimeters around the thinnest point in the cornea. They re-evaluated the enhanced best fit smear. And if you found a significant decrease in the BFS, indicating that the thinnest and the steepest cornea are correlating, that would pick up as a yellow or a red zone in your central maps for the anterior and posterior floats. With the progression indices, evaluating the cornea from the central thinnest point as you go out into the peripheral radius, 2, 4, and 6 mm zones are most important, and any deviation beyond plus or minus 2 standard deviation were considered significant. Defining disease progression was another important area where coefficient of repeatability is very important, and most of the devices we have, you cannot compare an OBSCAN to a pentacam or a pentacam to a Galili. In moderate to severe keratoconus, you may have a difference of even 1.5 to 2 diopters, even in the same patient, just taken 10 minutes apart. So looking at these data over a period of time, 6 monthly reviews, annual review subsequently, and then only you can actually label a patient as progression. Repeatability-wise, the Pentacam and Sirius were better than those with the Galilei and the other topographic devices. Looking at treatment modalities, the quality of vision in keratoconus is quite poor, and although a patient may be reading 612 on a BCVA, they do see a lot of starbursts, and in addition to defocus, vertical coma is the most common high-order aberrations they have. In these patients, it's definitely viable to suggest at least a contact lens trial, although some of them may be hesitant initially. Using a good RGP or a Rosquet contact lens would give a better quality of vision. For halting progression of the disease, cross-linking is the way forward, and in most patients, for better visual outcomes, however, if patients are not happy with spectacles, contact lenses provide an option. Do you have shape modulation in the form of Intax and TCAT as cares as well? And then finally, corneal transplantation in cases which do not have any further improvement. Toric ICL and toric IOL may not be FDA approved, and may be the only option in cases with diagnosed cataract or in cases where you want to debulk the refractive error. Cross-linking halts the progression of the disease right from the initial treatment protocols. They are indicated for progressive keratoconus at any age, even an age below 15 years. Now protocols have improved the safety of the procedure. Corneal pachymetry would be ideal to be more than 400, but however now thinner cornea protocols are there. You have to evaluate the corneal endothelium if possible, and minimum corneal curvature less than 40. Poor results are in patients with a younger age of presentation, associated eye allergy, a corneal pachymetry less than 400 microns, bilateral disease or inability to follow up, and significant change in spectacles or BCVA in the last 6 months. The exclusion criteria earlier was corneal thickness below 400, but however now almost up to 320 thickness corneal cross-linking has been done. Rule out any previous herpetic keratitis, central scarring already there, severe dry eye, a concurrent infection, autoimmune disease, and pregnant and nursing women. Here, the protocols initially established using ultraviolet A with a wavelength of 365 to 370 nanometers. With a better safety profile with the earlier protocols, even corneas lesser than 400 microns do not show any endothelial damage, and they found to be quite safe. Epithelial removal has found to have a better penetration of riboflavin in the stroma, and hence these corneas cross-link much better. Always check with your cross-linking machine the output energy, evaluate the distance of the UVA from the cornea, avoid too much of drying of the cornea or any possibility of secondary infection. And with the earlier protocol, a 30-minute treatment profile for 3 milliwatts per square meters was used. The side effects, you have to watch for microbial keratitis, especially in the first 4 days till the epithelialization is done. With most of the treatment protocols we follow now is 9 milliwatts per centimeter square for 10 minutes. TCAT treatment with cross-linking for keratoconus in patients who want a better uncorrected visual acuity allows for a limited ablation of 50 microns of the cornea. Aim is to regularize the cornea, improving the quality of vision and possibly improving the contact lens fit as well. It is not meant to give a complete refractive correction. The cases are mild to moderate keratoconus, a thinnest pachymetry more than 450 microns, and patients who are poor contact lens fits or unhappy with glasses. Rule out any allergic eye disease, ocular inflammation, or central scarring in the cornea. After removing the corneal epithelium in an 8 mm zone, the TCAT is performed at the optic zone diameter of 5.5 to 6.5 millimeters, and the maximum ablation is around 40 to 50 microns at the apex. The Athens protocol involved a PTK first, followed by a topo-guided PRK, MMC application for 30 seconds, followed by cross-linking. Combining cross-linking with photorefractive keratectomy provided improved in the uncorrected and best corrected visual acuity, and your case selection is very important in these patients. In contact lens fitting, I think Rose-K and RGP lenses are the most preferred in patients with keratoconus. Advanced keratoconus may require scleral lenses. DALC is the treatment of choice when you're considering keratoplasty in patients who are unamenable to any of the earlier techniques. DALC has an advantage to preserve the host endothelium and lesser endothelial loss, lesser chances of endothelial rejection. When it comes to penetrating keratoplasty, the indications have reduced now unless you have a very bad centrally scarred cornea. Even in a post-hydrops patient, you can start by doing a DALC procedure, and then if you have a large perforation, you can convert to PK. Although PK, keratoconus is the ideal indication with a long-term graft survival. However, the number of cases which require keratoplasty have diminished over the years. So in summary, we are looking at young individuals presenting with a very subtle onset of the disease, inflammatory markers, role of eye rubbing. A high index of suspicion is important. Try to pick up the early clinical signs and do a corneal topography wherever possible. To arrest progression, cross-linking is a well-established procedure. There's a lot of literature now on shape stabilization, and that requires a little more learning on which cases and how to do it. And finally, for visual correction, you have the Rose-K contact lenses. Thank you very much for patient listening.
Thank you, Dr. Sean, for an excellent presentation on keratoconus and its management.